Good morning, everyone. Welcome to Grand Rounds today. My name is Aditya Lati. I'm one of the Grand Rounds directors, along with Drs. Alex Harris and Rebecca Mueller. And today we have Dr. Alex Harris with us on Zoom. Today's Grand Rounds will be followed by a luncheon at 12:30 in the multipurpose room on the 6th floor. This luncheon is for trainees who have signed up. Okay. Next week's Grand Rounds will also be in person, and it's an unusual Grand Rounds because it'll be presented by 3 of our faculty, Drs. Catherine Monk, Danny Demetriou, and Rachel Marsh. The topic of their talk is the COVID generation, lessons from the Combo Initiative. This should be an exciting presentation, and it's also in person. So we invite you to come, but there'll be a Zoom link. Before I introduce today's speaker, I just wanted to give you a few housekeeping notes. We encourage everyone to ask questions. That includes in Zoom. If you're listening via Zoom, please use the Q&A feature, not the chat feature. If you're a trainee, we ask that you include the word trainee, as we like to prioritize trainee questions. Finally, if you would like to ask the question yourself on Zoom, indicate "can ask question myself." We highly encourage that. So use the Q&A feature, indicate if you're a trainee, and indicate if you'd like to ask the question yourself. Now, today, we have a very, very special speaker who's one of our own, and I can't really do justice to introduce him, so we're going to do that by having 2 of our own introduce him. So I'd like to welcome on the stage Christine Denny and Kate Elkington, who many of you know well, and also know that they co-ran the Grand Rounds directorship for the last 3 years phenomenally, and I think they could do a much better job introducing Jeff than I ever could. So Christine and Kate.
Hello, hello. It's good to be back. Have you missed us? Okie doke. So today we came out of retirement, and we would only come out of retirement for our dear friend Jeff Miller. And we are here to tell a little history of Jeff. In 1996, Jeff received his undergraduate degree from Harvard University, where he majored in biology. Now, the fun part of myself and Christine coming out of retirement is that we get to fill in the gaps of Jeff's CV. Jeff recently had a milestone birthday. I won't say which one. And Christine and I attended the party, and we learned that Jeff was in an a cappella group during his college years. So we're hopeful maybe today Jeff's going to bust out these skills and give us a little tune. In 1997, Jeff went to Paris, where he spent a year working on music composition, or maybe he was just touring with the a cappella group, we don't know. In 2002, he then completed his MD at Yale University School of Medicine, and from 2002 to 2006, he did his internship in internal medicine at NYPH and his residency in psychiatry here at Columbia. In 2009, he completed his fellowship in affective anxiety and related disorders, again here at Columbia, where he has remained.
Okay, oh, stopped earlier. Okay. I'm getting old here. So since 2009, Jeff has been one of our most beloved faculty. He is now an associate professor in the mind area, and he uses multimodal brain imaging tools to study the biological underpinnings of psychiatric disease with a focus on depression and suicide risk. He currently co-directs a multidisciplinary brain imaging laboratory with expertise in quantification of PET and MRI data. He actually conducted the first study quantifying the Kappa opioid receptor in major depressive disorder, identifying relationships between Kappa opioid receptor binding and depression severity for the first time in humans. Jeff has over 60 publications in top-tier journals. He's been funded by the NIMH, AFSP, the Davis Foundation, the BBRF, and the Hope for Depression Research Foundation. Jeff enjoys teaching residents, medical students, occupational therapy students. He is currently the psychopharmacology supervisor for PGY 3 and 4 psychiatry residents. In Kate and I doing this, we look through his CV, and he has a massive list of classes that he's taught or currently teaching, and it is really quite impressive and shows his love of mentoring. Outside of the lab, Jeff loves hiking and exploring with his family. He has 3 children, and Kate and I met them at his party, and honestly, Kate and I were so impressed with these sons. Like, they were just amazing, and Jeff has done such an amazing job raising them. Finally, who here has worked with Jeff? Can we have a raise of hands, okay? If you have worked with Jeff, you know how amazing this is. Everything gets done perfectly, okay? Right? On time, really enthusiastically, and in a super efficient manner. He can write a page-long email in 30 milliseconds, summarizing what needs to get done. Kate and I have enjoyed working with you, Jeff, beyond words. And I'm not just saying that we're up here. Like, we really loved working with you, and we are so blessed to have you in our life. And I think everyone in this room can say the same thing. And we just feel so touched that Adi asked us to come introduce you. And we cannot wait to hear about your exciting science and are so, so proud of you. So with that, the title of Jeff's talk is The Relation of Neuroinflammation to Depression and Suicide Risk. So.
Hi, I'm a little bowled over. I'm gonna need to collect myself. It's great to be here and to see so many friends and colleagues and to tell you about the work that I've been doing in recent years with a really collaborative team. And I will try to highlight some members of the team as we go through. I just want to share my disclosures, which are research support for 2 studies from pharmaceutical companies unrelated to the work that I will describe today, and a private practice in psychiatry, also unrelated. I will speak a little bit about off-label use of medications, but it's not related to any financial conflicts that I have. A brief overview. I'm going to widen the scope of what I'll discuss today a little bit from the official title. And I'm going to talk about 2 stories that are related. They both are about how the brain transduces or responds to stress in a maladaptive way that may relate to risk for depression and suicide. So we'll speak a little bit. Let me just see if I can switch the pointer. Oh yeah. Oh, Simon, can you do it while I'm talking? We'll speak a little bit about the Kappa opioid receptor, and then we'll talk about a marker of inflammation in the brain, its relationship to depression, suicide risk, life stress, and the microbiome. Thank you, Simon. So just a little bit of context, which I think will be familiar to many in the audience, but I'll just spend a little bit of time on it. First of all, we know that depression is a highly disabling illness. It is a leading cause of disability globally in terms of disability-adjusted life years, which is a metric from the World Health Organization. And of course, the most severe consequence of depression is suicide. And when we think about the lifetime prevalence of major depressive disorder in the United States, about 1 in 6 individuals in the US will suffer from major depression in their lifetimes. This estimated rate of completed suicide is really quite a stark number. And we're not great at treating depression currently. So with our first-line evidence-based pharmacological treatments for depression, we get about 1/3 of patients treated fully to remission with a first trial. Some of that, we believe, is related to the heterogeneity of the illness. And if you think about the way we diagnose a major depressive episode with at least 5 out of 9 symptoms, some symptoms of which can go in one direction, like oversleeping, or in the other direction, like insomnia, you can think about the significant clinical heterogeneity of the illness. And we think that that likely reflects some underlying biological heterogeneity as well. I hesitated whether to throw in this quote, but I decided to do it at the last minute. It's something that I actually think about a fair amount about our psychiatric diagnoses generally and major depressive disorder specifically. In diagnosing depression in this way, are we really carving nature at its joints? Is this a distinct class, and is it the best way to think about diagnosis and therefore treatment? And what we'll talk about, this is a little bit of foreshadowing, but we'll look at a fair amount of biology today in which we're not seeing group differences as a function of a diagnosis of major depressive disorder as compared to individuals without depression. But what we are seeing is relationships within the depressed group between a symptom measure and a biological measure. So there are a lot of theories about the causes of depression, and I think a lot of them can be integrated into this general rubric about a stress diathesis or diathesis stress model in which some underlying diathesis, some underlying risk, which may be genetically conferred. We know that the heritability of depression is about 30%, interacts with life stress to lead to a depressive episode. And what I tried to illuminate in this not super elegant figure is that people can be at different ends of that spectrum. Someone with a high genetic loading, a dense family history of depression, may develop depression even in the absence of significant obvious life stressors, and that can actually be quite confusing to those individuals. They may feel like, I should really be able to tough this out. And conversely, individuals with a low biological diathesis may develop depression in the setting of high psychosocial stressors. Both early life stress and recent life stress, we know, are risk factors for the development of depression. And so in the stories that I'll share with you today, we're gonna zoom in on this, and we're gonna talk about how stress may act in the brain to predispose to depression. So the first set of data that I wanna share relate to the Kappa opioid system in the brain. Many in the audience may be more familiar when you think of opiates, both prescribed medications as well as drugs of abuse. Those are drugs that act preferentially at the mu opioid receptor. The Kappa opioid receptor is another receptor in that family, and it has an endogenous Kappa opioid in the brain, which is called the dynorphin system. So dynorphins are Kappa opioids. There's really elegant literature in animals that in response to stress, the HPA axis is activated, the hypothalamic pituitary axis, which leads to release of cortisol, and that in turn leads to the release of Kappa opioids in the brain, which have a series of, in animals, maladaptive effects. They stimulate the Kappa opioid receptor, and they inhibit release of several monoamine neurotransmitters, norepinephrine, serotonin, and dopamine. And in terms of what we can study with PET imaging, that stimulation of the Kappa opioid receptor also leads to internalization and downregulation of the receptor itself. So when this Kappa system is activated, the receptor levels go down in animals. Consistent with, I just want to make one point, the decrease in dopamine release occurs in the reward circuitry in the brain, the ventral tegmental area projecting to the nucleus accumbens, which is related to both experiences of pleasure and then to reward anticipation. In animal models, stimulating the Kappa receptor therefore leads to place aversion, something akin to anhedonia, and blocking the receptor has an antidepressant-like effect in multiple models, animal models of depression, and there are transgenic mouse findings that are analogous. So we were interested in this system. It's a stress-responsive system, and in response to stress, it leads to depression-like effects. If you block it, it leads to antidepressant-like effects. And so we were interested in translating these findings to humans. What we looked in the literature at is where this was happening in the brain in mice. And when you stress an animal or when you activate its HPA axis by giving it corticotropin-releasing factor, there's a very specific anatomic pattern in the brain of where the Kappa opioid receptor is stimulated. These 4 brain regions were the regions that were found to have the highest levels of stimulation. Okay, so we sought to translate those animal findings into humans. We wanted to look at both early life stress and recent life stress, which can be assessed via questionnaires and interviews. We wanted to look at activation of the hypothalamic pituitary axis by measuring salivary cortisol responses to a laboratory social stressor, depression-like effects, looking at diagnosis and severity, and the levels of the Kappa opioid receptor using PET imaging, which I'll talk about a little more in a moment. I colored these little figures to show the hypothesized relationship. Based on what I had just described, we hypothesized that Kappa opioid receptor levels would be inversely related to life stress, HPA axis activation, and a diagnosis of depression. We used PET imaging, and I'll just mention a little bit about that. PET imaging is a brain imaging modality that involves injection of a low dose of a radioactively labeled drug that goes through the blood, into the bloodstream, crosses the blood-brain barrier, sticks to a molecular target in the brain, and allows us to see where and how much that tracer is accumulating in the brain. It's a very powerful tool because any drug that you're able to radio label and get to cross the blood-brain barrier, it's a little more complicated than that, but a wide array of drugs that could do that could be used as a probe to image different aspects of brain chemistry. And so it can be used to image serotonin, norepinephrine, dopamine neurotransmitter systems, mu and kappa opioid systems, and some other markers that I'm listing here. And I'll just note briefly that we are very interested, our lab, in collaborations with the department broadly. We have active collaborations with Blair Simpson, using a marker of inflammation in OCD, with Raghi Gurgis using a synaptic density marker in schizophrenia, and with Trevor Griffin and Joanna Steinglass looking at dopamine reward responses in bulimia. And we welcome more. So this just shows you what a PET image looks like. This was from our study, a mean image of the healthy volunteers, where you can see the density and distribution of the kappa opioid receptor. Okay, I'm going to go through some negative findings, and then we'll get to some positive findings. In our first analysis, I showed you those regions in the mouse brain that are activated in response, where the kappa system is activated in response to stress. That's where we started. We saw no difference in kappa opioid receptor levels in humans in those same brain regions as a function of a diagnosis of depression. Similarly, in those 4 regions, we saw no relationship to life stress, early or recent life stress. We did, however, see a trend level relationship in the hypothesized direction with the HPA axis system, such that higher levels of cortisol response during a social stressor were associated with a lower level of kappa opioid receptor binding, suggesting kappa system activation, and that there might be some relationship between those 2 stress systems that had been seen in the mouse, the HPA axis and the kappa opioid system. It may be that our measures of life stress that I showed were looking at wrong time periods, were too crude a measure, that it might be, like within a time scale of days or weeks of stress levels rather than months or early life that may be mediating this system. We then, with a postdoc at the time at Yale, Kelly Smart, decided to take a secondary look at the data in a different way. As I mentioned, we started in this very hypothesis-driven manner in terms of the brain regions that we looked at. We decided to zoom out and look at the structure of the kappa opioid receptor system in the brain by looking at brain regions whose kappa receptor binding were correlated with one another using independent component analysis. This serves 2 purposes. One, it reduces the number of comparisons we have to make when we are looking across the brain. And it also lets us know something about which brain regions kappa is relevant in. And so we found 3 components of binding. And what we were really excited to see is that in one of those components, there was a strong, significant relationship between kappa opioid receptor levels and depression severity, explaining about 70% of the variance in depression severity in this sample. That component included anterior brain regions, it heavily weighted brain regions, including anterior cingulate, insula, dorsomedial prefrontal cortex. These are brain regions that are involved in the salience network in the brain, which plays a role in conflict monitoring and orienting attention toward behaviorally salient stimuli. They're also brain regions that have been implicated in many past studies with different brain imaging modalities in pathophysiology and depression. So we're very excited about that. We did not see with any of those components of kappa binding differences as a function of a diagnosis of depression. So there were no differences between healthy volunteers and patients. It was within the patient group. where we saw these relationships. Okay, so to summarize that, consistent with animal studies, we found relationships in the hypothesized direction between the HPA cortisol stress response system and the kappa opioid receptor system. Validating and providing some forward translation about the link between these two systems. And we found when we zoomed out from our I'll also say those 4 a priori brain regions are very small brain regions. And when the component, I'm sorry, I want to make one more point here. The component where we found these relationships with depression severity includes anterior cingulate, which is one of the brain regions with the highest levels of kappa opioid receptor binding. And so we were probably improving our signal to noise ratio when we looked where there's kappa signal in the human brain rather than what this a previous mouse study showed us. And that's where we found these hypothesized relationships between a measure of depression severity and the kappa opioid system. Great. And right, I just want to make a point that there's value to narrowly hypothesis-driven work. There's also value to data-driven work where you just look empirically everywhere you can. This work is now will soon be followed up through a funded K award by Betsy Bartlett in Area Mind, who's going to be looking at some more novel stress paradigms. And I don't want to say too much about it, but in a more novel, compelling way, relating stress responses to kappa binding in a much cooler way than I did. So I'll leave that to her to tell someday soon, hopefully. There's a literature about the kappa opioid receptor in substance use disorders as well, and that kappa in animals mediates stress-induced relapse to substance use. And Diana Martinez in our department has published some really interesting work about the role of the kappa opioid receptor in cocaine use disorder and alcohol use disorder. And so as we think, about patient groups where this neurochemical system may be of particular relevance, I do think about co-occurring substance use disorder and depression. So stress-sensitive depression, co-occurring substance use, and mood disorders, I think are places where the kappa opioid receptor system may be particularly implicated. And that's an area that I'm interested in studying in the future. We've had conversations with Nasser Naqvi and Fran Levin about going in that direction. There are several medications that have kappa antagonist properties. And now I'm, disclaimer, off-label. None of these are FDA approved for this use. But I'll just mention a couple of the medications. So buprenorphine, which I think we often think about for its mu properties. It's a partial mu agonist and is used in the treatment of opioid use disorder. In addition to being a partial mu agonist, also has kappa antagonist properties. There are some studies with low-dose buprenorphine that have found anti-suicidal effects of low-dose buprenorphine, a study from Israel that found that, a placebo-controlled trial. And so it may be, there's Jonathan Javich and others have interest in mu effects in depression, but it may be that the kappa effects are playing a role in those observed findings. There's a branded medication that was FDA approved a few years ago called Lybalvi. That's a combination of olanzapine and samidorphan. It was FDA approved for the treatment of bipolar disorder and schizophrenia, and the samidorphan is used to mitigate the metabolic effects of olanzapine, but that also has kappa antagonist properties. And then there's a medication that has bounced around to multiple pharmaceutical companies called aticaprant, which is in a development pipeline for depression that is a kappa antagonist. So we are interested in doing more work, potentially using a personalized medicine approach. As these data show, it doesn't look like there's a kappa abnormality in all patients with depression, but there might be selected populations where using a kappa antagonist might be particularly beneficial. Okay, great. I'm going to shift gears and talk about neuroinflammation and depression. There's been, I think, a lot of interest in the role of neuroinflammation across psychiatric illnesses in recent years. The term is sort of a broad term, and so I'll try to, and I think we sometimes in the field use it in a slightly hand-wavy way. And so I will try to drill down with a little bit more specificity about what we mean when we talk about neuroinflammation. I'll also say that we have to be modest in terms of the tools, the brain imaging tool that I'll present today, in terms of how much it tells us about the details of neuroinflammation. So there are several different, so one definition would be the interplay of the immune system and the central nervous system involving pro-inflammatory cytokines, chemokines leading to microglial activation, and astrogliosis. So some interaction, some activation of the immune system that may have detrimental effects on brain structure or function. Microglia are phagocytic, like meaning eating. They eat, consume components, cells, toxic debris, cells that are the macrophage-like cells of the central nervous system. They're part of the innate immune response, which is the early response that precedes the adaptive immune response. And so elements of the innate immune response recognize kind of ubiquitous marks on bacteria that are not highly specific to an individual species of bacterium or a virus, for example, like the innate immune response, for example, that involves specific antibodies. So they're the fast response, fast, non-specific, are part of the fast, non-specific innate response to infection. So how does that get us to psychiatric illness? Well, there have been observations that a third of patients with depression have elevated inflammatory biomarkers, so cytokines and chemokines that are released by cells of the immune system in response to infection, injury, or as we'll talk about soon, stress. Those include C-reactive protein. The findings in depression include C-reactive protein, TNF-alpha, IL-6. Autoimmune conditions of the central nervous system, like multiple sclerosis, are associated, or inflammatory illnesses more generally of the central nervous system, are associated with higher comorbidity of depression. So there again is some indirect connection between inflammatory conditions and in the brain and depression. And then sickness behavior. So this is a phenomenon that is described in response to infection. If you think about like the last time you had the flu, or COVID, although that's a more complicated case. But when people, or even just a common cold, if you think about how you feel at that time, the sickness behavior phenomenon includes decreased motor activity, social withdrawal, reduced food and water intake, increased slow wave sleep, increased core body temperature, and altered cognition. So that's a pro-inflammatory state in the setting of infection. And there are a lot of symptomatic overlaps between that sickness behavior state and some of the symptoms of depression. When we give immune modulators in cytokines like interferon alpha to treat medical conditions such as hepatitis, there's a high incidence of depression. That's a known risk factor for those kinds of treatments. And we spoke about this, that particularly in treatment refractory depressed patients, we see elevated pro-inflammatory immune markers. So I'll tell you a lot more in a moment about a marker of inflammation that we can quantify using PET imaging called TSPO. And there are several studies that preceded the data that we're going to talk about now that showed elevations in this PET marker in depression. So in the central nervous system, first of all, it's an immunologically privileged organ. The blood-brain barrier prevents a lot of substances from entering the brain. But it has, as I said, these native macrophage-like cells, the microglia. They respond, as I've been describing, to infection. They also respond to tissue damage or injury, but perhaps most relevant to depression, they also respond to stress. Through the HPA axis, again, glucocorticoids, cortisol, and through norepinephrine, the catecholamine stress responses, like a fight or flight response, microglia are activated. And it used to be thought that there were these sort of two activation states of microglia, and that they toggled between the two, like a pro-inflammatory and an anti-inflammatory state. We now understand that it's more complex than that, and that they probably exist in a continuum. But in response to stress, there are many downstream effects that involve activation of pro-inflammatory cytokines. They can have impacts on synaptic remodeling. They can phagocytose apoptotic cells as well. They can remove cell debris. So some of their responses to injury are adaptive, but the thought is that if they are activated excessively, that could cause maladaptive responses and damage to brain structures, to neurons, to synapses. I'll just say, I mentioned we're focusing here on stress. There is a literature about infection and post-infectious psychiatric illnesses. So, there's this condition that is contentious. The diagnosis is a little bit contentious of pandas, but that is a post-infectious, acute, early onset of OCD symptoms in kids following strep infection, and there's a more broad concept called PANS, which could be even following other types of infections. And so while I'm focusing on how stress may activate the immune system today, there is a literature also about how infection and some induced autoimmunity may impact the central nervous system. And Blair and I are interested in looking at that in some of our work. Okay, I think we've covered most of this, but I'll just say that inflammatory system activation may also impact neurotransmitter systems. It may impair neurogenesis. We know that in the dentate gyrus in the hippocampus, neurons continue to grow into adulthood. And there are theories and data about hippocampal atrophy in depression. So inflammation can impair neurogenesis. It can, in turn, activate the HPA axis. And these are theories about how inflammation may impact brain structure and function in ways that would predispose to depression. So back to PET and getting soon to the data. There's a protein on the surface of the mitochondria called TSPO that is present in microglia. It may be more present in activated microglia, but it certainly scales with microglia cell number. It also is present in astrocytes, another glial cell in the brain, which may play a role in inflammation. And we can quantify that with PET. This is showing you an average image of a large number of PET scans that we've completed in our group. And so this next set of work that I'm going to talk about was done collaboratively with a large group, working very closely with my mentor and collaborator, John Mann, and a large team who I will point out as we go through. When we looked at these brain scans, we had a set of brain regions that from previous PET imaging studies with TSPO seemed to be associated with depression, that we had specified as a priori regions that we wanted to look at more closely for their relationships to depression, measures of suicidality, and to life stress. And when we looked across the brain regions that we had pre-specified, we found that the TSPO signal was very, very highly correlated across those brain regions. And so rather than focus on one brain region at a time, we thought that it made the most sense, again, to reduce the number of comparisons that we had to make, to look at an average measure of TSPO binding across those brain regions. So the first thing that we've looked at and I should also say, we're using a third generation tracer for TSPO that has advantages over several of the previous generation tracers in terms of its signal to noise, but also in terms of its ability to quantify signal across a range of genotypes in the TSPO gene. With all of the previous PET tracers prior to the current generation, you would have to do a genetic test, and if someone was of the low affinity genotype for this gene, you would have to exclude them from the study because the PET tracers they weren't sensitive enough to detect for that signal. We now just covary for the genotype. So all the data I'm going to show you are covaried for genotype. In a large sample, one of the largest samples that has been collected to date of TSPO PET and depression, again, a similar story as we saw with Kappa, we don't see a diagnosis effect. There's no difference in TSPO binding between patients with depression and healthy volunteers. We had hypothesized that the depressed patients would have higher binding. And several previous studies had, in fact, shown that, as had a meta-analysis. However, when we drilled down into symptom severity, looking at depression severity using the 17-item Hamilton, we found a significant effect such that patients with more severe depression show higher levels of TSPO binding. We looked at another measure of depression severity, the Beck Depression Inventory, which a couple of differences. It is a self-report measure, but it also emphasizes and samples more heavily the psychological and emotional symptom domains in depression, whereas the Hamilton emphasizes and weights more heavily the more physical symptoms, what are called the neurovegetative symptoms. We saw a significant positive relationship such that patients with more severe depression have higher levels of TSPO binding. Then we started to look at life stress. Early life stress, childhood physical, sexual abuse, and neglect was not related to depression in a statistically significant manner. But recent life stress, using a measure, a semi-structured interview called the St. Paul Ramsey scale that assesses a range of life stressors over the last 6 months, was positively associated with TSPO binding. I just want to, she's been on the top right corner, but I just want to point out Betsy Bartlett, an outstanding assistant professor in our research group who conducted these analyses. Betsy looked to see if there was a mediation, if the relationship between recent life stress and depression was mediated by TSPO binding, and she found that it was, such that in the setting of high recent life stress, there was a stronger relationship between TSPO binding and Beck and depression severity. And so this gets to, this question about, we spoke about the stress diathesis model. So the diathesis is some underlying biology, and then stress interacts with it. But how does that stress interact with it? Well, with the diathesis to produce depression. This is providing some data that perhaps the stress leads to increases in neuroinflammation in this marker of inflammation that may have maladaptive effects on brain function, and that may lead to the development of depression. And these data are very consistent. Again, there's a forward translation here. In animal models, if you stress a mouse, microglial activation is observed, as well as depression and anxiety-like behavior. And if you block microglial activation through knockout models or through an anti-inflammatory medication like minocycline, this ameliorates the symptoms, the behavioral phenotype. Great, so we were very excited about that. I'm now going to shift gears, still talking about TSPO, but talk about suicide risk through the measures that we quantify, which in vivo, which are suicidal ideation and suicide attempt history. And I want to give a shout out to Sarah Herzog, who led these analyses and also did an outstanding job with them. What I'm showing you here is a great visualization that Sarah made of responses during ecological momentary assessment. So this is a type of survey in which participants in our study answer questions in a survey on their smartphone 6 times, up to ideally 6 times a day over the course of a week. And it's a way to prospectively sample individuals' mood states, suicidal ideation, as opposed to having people recall how suicidal were you, what types of thoughts have you had in the past 2 weeks, right? It's prospectively acquired data. This work was initiated by the late Barbara Stanley in Area Mind, who was a mentor of Sarah's, in close collaboration with Hanga Galfalvi. And Sarah's done a really outstanding job of relating these EMA data to PET. And so each line on this image is an individual participant. And the x-axis is time. Each dot represents one survey response. So there, as I said, there could be up to 6 in a day. The size of the circle represents the severity of suicidal ideation that they endorsed in that time point, which is, on average, a few hours from the previous survey response, right? And the color represents whether during that epoch, that survey, they also described a clear stressor. So red dots are stress-associated suicidal ideation, blue dots are non-stress associated suicidal ideation, and larger dots are more severe ideation. And what I think is really interesting, just qualitatively, I found this plot so fascinating to see individuals whose suicidal ideation sort of has these crescendos or decrescendos, some in like a gradual way, whereas here it's like quite acute onset, going from very low levels or none to very high levels. And then that there are people who describe stressors throughout the week where they are completing the surveys, people whose suicidal ideation seems to be less stress associated or more stress associated. So we had 3 types of clinical data that we sought to relate to this marker of inflammation then with respect to suicide. One was a presence or absence of a past suicide attempt. One was the Beck scale for suicide ideation, an interview where we ask about suicidal ideation in the previous week, and these prospective measures of suicidal ideation through the EMA. In general, the EMA was done prior to the PET scan, on average about 10 days away from PET scanning. So we're not predicting future ideation in general, but we're looking at ideation close in time to the PET scan. So the one thing I just want to show you is if we collapse all of the suicidal ideation measures we have, do people who endorse any suicidal ideation through the EMA or the interview differ in their TSPO binding? And the answer is yes. People who had suicidal ideation around the time of PET had higher TSPO binding than individuals who were not experiencing suicidal ideation. And then this is the EMA data specifically. And what we saw was a stronger relationship between stress-induced or stress-associated ideation and TSPO binding than to suicidal ideation as a whole, such that within epochs where stress was endorsed, suicidal ideation severity scaled with TSPO binding, but not in the non-stress epochs. And we saw something similar with negative affect that was reported during EMA. There was a main effect, actually, of negative affect. The greater your TSPO binding, the more negative affect you described during this period of EMA monitoring. But there was also this interaction such that it was an even stronger effect in stress epochs than in non-stress epochs. In terms of suicidal ideation severity through the interviews, there was a trend level finding of greater endorsed suicidal ideation through interview being related to TSPO binding. And then I will say previous literature, I should have framed this a little bit more. There's a gap in the literature about these rigorous assessments of suicidal ideation and attempt. There were, like a measure from the Hamilton or something like that was previously associated with TSPO binding in the literature, but this is a much more rigorous assessment of suicidal ideation and behavior than previous TSPO studies. We had also hypothesized that a history of suicide attempt would be associated with TSPO binding, and This has not reached statistical significance, although we hope to expand the sample greatly. Numerically, you can see that it's in the hypothesized direction. And a real caveat to the data we've collected thus far is about the timing, the latency, the lag between individuals' most recent suicide attempt and the time of the PET scan. On average, the suicide attempts occurred 5 years prior to the PET scans. You can see that there's a cluster that had PET scan within 1.5 years or so of PET, but as I'll describe in a moment, we really think that it'll be very important to do this kind of imaging, much more acutely in the setting, immediately after an attempt. Okay, so this is the first study, this set of data that I've just described is the first set to show relationships between TSPO binding, this marker, imperfect marker. I haven't told you all the ways it's imperfect, but it is an imperfect marker of inflammation. Linking that to prospectively measured suicidal ideation through EMA monitoring. It's the first study that I believe to show these relationships to recent life stress. And this mediation, that TSPO mediates the relationship between life stress and depression severity. So as I said, we really want to hone in and have plans to and are plan to collect more data, honing in on individuals in suicidal crisis, either who are hospitalized due to suicidal ideation or following an attempt, to really understand. It really seems like it's a proximal relationship, right? Like, so for example, also zooming out, we didn't see relationships between childhood trauma and TSPO binding. We didn't see a main effective diagnosis. We think that there's something about, like, it seems to reflect a state measure rather than a trait measure, the TSPO relationships that we're observing. These findings, the suicidal ideation relationships, certainly make us interested in doing further work to evaluate anti-inflammatory medications and their possible role as anti-suicidal interventions. And I think the other thing that I would say, similar to the point that I made with Kappa, is since we're not seeing a main effect of diagnosis, studies that examine an anti-inflammatory medication just simply in a group of patients with major depressive disorder I think are unlikely to show clinical effects. And it seems that we really will likely need to tailor clinical trials of anti-inflammatory interventions in depression to individuals who have some evidence of a pro-inflammatory phenotype. PET imaging could certainly play a role in that, but we are also interested in looking at other measures. Okay, in the last 10 minutes, doing well on time, I'm going to talk a little bit about the gut microbiome, which Elizabeth Sublette and I have developed a lot of interest in and a really fruitful collaboration in recent years. So I hope some of you were at John Cryan's Grand Rounds 2 weeks ago, which was really an amazing talk about the gut-brain axis, and he's a global leader in trying to look at gut microbiome contributions to psychopathology in humans, really done a lot of animal literature that we're now trying to translate forward, as he is, into humans. And so there are several ways in which the healthy bacteria in the gut may influence and communicate with the brain. Those include metabolites that are produced by bacteria in the gut. They include signaling via the vagus nerve. They include relationships between the distribution of the gut microbiome and pro-inflammatory cytokines in the bloodstream. There have been so some of this was summarized by John Cryan, so I won't spend too much time on it, but a really powerful paradigm to understand the role of the gut microbiome in brain structure, function, development is to compare mice with a healthy microbiome to germ-free mice who are raised in the absence of a microbiome. And what are seen in these contrasts are significant differences in the permeability of the gut, in the blood-brain barrier permeability, differences in impacts on neurogenesis, on microglia, the cells that we've been speaking about today, myelination, and even neuronal survival. So, as I mentioned, Elizabeth and I became very interested in this and decided that we wanted to try to pursue it in depression in humans. We started by doing a review of the literature, the existing literature at the time of findings of gut microbiome abnormalities in depression. And while there was some consistency in findings at the time, there was really not a consistent story that could be told. Most of the studies at the time were relatively small samples, different patient populations, different diets. It was which can impact the gut microbiome, and it was really hard to tell a really simple story at that time about gut microbiome abnormalities in depression. I will share my favorite study that we reviewed and described in that paper because it speaks to causality. I will say a lot of the data that I've shared with you today is correlational and cross-sectional. This is a causal study about the role of the gut microbiome in depression. And so what this group did is they collected stool samples in patients with depression and healthy volunteers, and they quantified the gut microbiome, the fecal microbiome, through DNA sequence or RNA sequence analysis, and found differences in the microbial distributions between patients, humans with depression, and healthy volunteers without depression. They then took stool samples from those humans and transplanted them into germ-free mice without a microbiome. And what they found is that the mice who received the microbiome fecal transplant from patients with depression developed depression-like behaviors. And those who received the stool transplant, the fecal transplant from the healthy volunteers, compared to those who received the stool from healthy volunteers. So I was just sort of bowled over by this. And John Cryan 2 weeks ago showed similar findings of fecal transplants into mice, this sort of reverse translation that speaks to causality with respect to aging. Okay, after we published our review, 2 very large, far better designed studies than anything that had existed at the time of our review were published. One with a sample of 1,000 individuals that they confirmed in another 1,000. And in that study, they looked at both quality of life measures and depression symptoms. And they found 2 bacteria, Coprococcus and Dialister, that were found to be present in lower relative abundance in depression. They were higher in healthy individuals, lower in depression, associated with greater quality of life. Coprococcus was then replicated in another N of 2,000 study. So there's now an N of 4,000 that have implicated Coprococcus as being potentially protective against depression. And Dialister was not replicated in that second study. There were several other bugs that were found. I'll just note here that Coprococcus and Faecalibacterium, which was associated with improved quality of life, are butyrate producers, and we'll get back to that, but it is a substance, it's a short-chain fatty acid. Actually, I'll just say it's a short-chain fatty acid that improves gut membrane integrity and thereby has anti-inflammatory properties. Yeah, it's important to say that because when Elizabeth and I saw that, we were really interested in then looking at our measure of inflammation in the brain. Here's this bug that has been found to be associated with resilience against depression and has anti-inflammatory properties. And so we hypothesized that it would be less abundant in depression or associated inversely with depression severity, and that it would be associated with lower levels of TSPO binding. So we collaborated with Anne-Catherine Uleman. If any of you do microbiome studies at Columbia, you may be collaborating with her already. She runs the microbiome core lab here. She's in the Department of Infectious Disease. She's an outstanding collaborator. And if you're interested in getting into this kind of work, I would strongly recommend that you reach out to her. So I spoke about those samples like in the thousands. Our sample is very small, right? This is a PET imaging study, but we obtained stool and actually saliva samples. I'm not going to talk about the saliva data today, but to look at the oral microbiome as well. And I'm going to give you sort of a high level look, mostly in the interest of time and also just because these data are quite new, at what we're most excited about in these data. What we're most excited about is that we confirmed our hypothesis that coprococcus and dialister were associated with lower levels of TSPO binding in the brain. And this is rigorously corrected for multiple comparisons. There are several other bugs that were as well, and some bugs that were associated with higher levels of TSPO binding. Oh, and I just also want to make a shout out to Peyton, a fabulous medical student who's helping us write up these data right now. And then, again, the things we're excited about that were consistent with our hypothesis. Here's coprococcus again, which, as we had hypothesized, is associated with a lower level of depression severity. So consistent with those large community findings. Again, other bugs, I'm not really going to drill down into so much detail about those others. And we also looked at suicide attempt history. And here's again coprococcus, associated, found to be increased relative abundance in the non-attempters as compared to the suicide attempters. When we looked at as a function of depression diagnosis, we did not see those two bugs that we hypothesized, dialister or coprococcus. But I think you're seeing a kind of a theme in what I've described today, that we're really seeing things, biological measures, the most significant biological measures in the work I've presented today are related to symptom metrics rather than a categorical diagnosis of depression. There were many bacteria that were associated with depression, both higher and on both ends of the tail. There are these summary metrics that we look at when we're looking at the microbiome as a whole, rather than the relative abundance of a specific bacteria. Alpha diversity refers to the diversity within a single group, a single population, like a group of healthy volunteers or a group of patients with depression. And it looks at the richness or the number of different species. That's what Chow emphasizes. Or it can look at both the richness and the evenness of the species, and that's what Shannon emphasizes. We didn't see any differences in alpha diversity as a function of diagnosis. And then beta diversity looks at two populations to look at whether they, the similarity or dissimilarity between two distinct communities. Similarly, we didn't see differences in beta diversity comparing patients with depression to healthy volunteers. Although if you look in the depressed group, there is, the samples are very small, but there's potentially a cluster that is within the same space as the healthy volunteer group, and potentially a cluster that's, expanding that distribution. And I'll just make one point about that. When we look, this is another way of looking at the sample. Each vertical line is one participant, and the colors represent the relative abundance of different bacteria. Prevotella was one of the bacteria that was of greater relative abundance in depression. And just, again, qualitatively, it looks like there may be a subgroup of patients that particularly have high levels of Prevotella. We want to drill down into that. Okay, so what I'm most excited about is the coprococcus finding that it seems to be related to lower indices of severity with respect to depression and suicide. It has demonstrated anti-inflammatory properties, and we are seeing that it's associated with lower levels of TSPO binding in the brain. This is our first gut-brain axis finding, which we're really excited about. There's data that butyrate can actually cross the blood-brain barrier as well, and that butyrate supplementation can limit microglial activation and the secretion of pro-inflammatory cytokines. The dialister findings were mixed. The Prevotella findings were confusing. I didn't go into it much, but it was increased in depression, but decreased in a high inflammatory state and associated with less severe depression. Prevotella is a genus, not a species, and it may be that some of these opposing findings are explained by the limits of the resolution of the genotyping, and that it might be that there's one species of Prevotella that is contributing to inflammation or to depression risk, and that one is protective, and we need to do more work to drill down into that. So we want to confirm these data in larger samples. We want to do mediation analyses to see if TSPO binding mediates the relationship between Coprococcus relative abundance and depression severity or other metrics. And then we want to do reverse translational work. And Chris Anaker in our department is also very interested in doing microbiome analyses, has collected stool samples, and has some really exciting preliminary findings looking at the microbiome with respect to his different stress models. And so we are hoping to do kind of forward and reverse translation with him in future studies. And then, ultimately it would get to the point of like therapeutics. And it's really not so clear how you can change the gut, it's not easy or trivial to change the gut microbiome. And some studies of probiotics in depression, where they quantify the gut microbiome before and after a course of an oral probiotic, don't show changes in the gut microbiome distribution. And so John Cryan spoke about this last time about prebiotics, probiotics, all these diet, right? There are many different ways that you could modify the microbiome, but it's not so clear, and there's not like a Coprococcus available like on the shelf at the local pharmacy that's been studied in humans yet. So, but we're interested in getting there. Okay, I'm going to stop there. I want to thank a really amazing multidisciplinary team that I work with, that I feel very fortunate to work with, and I thank you for your time and interest, and would love to take some questions.